myself Dr. Sagar Khetia. I am Assistant Professor at UN Mehta Cardiology Institute, and today topic of our discussion is coronary guidewires. So interventional cardiology branch has grown significantly over last few decades, and coronary guidewires has remained central key component of along with this growth. Initially, Dr. Dotter and Judkins first used guidewires. They used sprinkle guidewires with series of large rigid dilators. Then in 1977, Dr. Andres Grosnis replaced these dilators with inflatable balloons, and he used polyvinyl chloride balloon catheter with sword fixed guide wires attached to its tip. These guide wires has a low success rate, and success of procedure largely depended on luck. First revolution came with invention of over-the-wire balloon by Dr. John Simpson. He used movable steerable guide wires within the balloon dilation catheter's central lumen. This resulted in significant improvement in success rate of PCI procedures. So guide wire selection is the first critical step of any cardiology procedure, which determines success of lesion crossing and device durability along with procedural time, safety and outcome. Selection of guide wire depends on type of lesions, its characteristic, and it also depends on operator's understanding of guide wire design and behavior. So first we will review what are the building blocks of guide wire. So there are four main components of guide wire. First is the core, second is the body, third is coating, and fourth is a tip. So we require different kind of wire characteristic to deal with different kind of lesions. So first we will discuss what are those characteristics. So first is torqueability. It is ability of transmit to rotatory force when applied to proximal end of the wire to transmit the distal tip. Another is flexibility, which as name suggests ability to flex the wire along its longitudinal axis. Third one is shapeability. It is ability to modify guide wire distal tip according to different lesion anatomies. Fourth one is shape retention. It is ability to retain intended shape by guide wire despite of exposure to different deformatory stress. Another is tactile feedback, which is a physical sensation felt by operator at the proximal end of wire during wire advancement. And trackability is ability to follow the tip and advance smoothly along the vessel stenosis and occlusions. So different components have different function. Core has mainly function of to provide stability and to improve tactile feedback and better tip control. While tip has function in stability and maneuvering. Body has main function in trackability. While coating reduce the friction and improve trackability. While absence of coating provide better tactile feedback. So first we see core. Core has main three components: core material, core diameter and core tapering. Core material has formed from either stainless steel or nitinol, and currently high tensile strength stainless steels are also used in some wires. So stainless steel and nitinol both have some advantage and some disadvantage. So main advantages of stainless steel is good torqueability, good support and good tactile feedback, while it came at the cost of less flexible and more susceptible to kinking. While nitinol has advantage with its flexibility, its kink residency and more durable, but it has less torqueable and less tactile feedback. So this is again shows nitinol core is used in workhorse wires while dealing with standard lesions and complex lesions and CTO required good support. So stainless steel is more used. Another technology has come, composite core technology, where it is employed by Asahi brand, which use rope coil and twist wire to improve good support and to provide better flexibility. Another component is core diameter. Smaller the core diameter equals to more flexibility, while larger diameter is equal to more support. Another is core tapering. So when there is a shorter core tapering, it provides more distal support and better torque response, but it came at the cost of increased chance of prolapse. While larger longer tapering upward result in better steering and trekking with less likely to prolapse, but there will be less distal support. So tip design. There are two kinds of tip design. One is core to tip and another is sapping ribbon. In core to tip type of design, core tip reaches up to the end of the wire, while in sapping ribbon design, core terminate early and distal most part is formed by flexible metal strip, which refers to ribbon. So what are the advantages of core to tip design? With this design, we have precise tip control, better force transmission, and increased support with better tactile feedback. But there will be decreased flexibility. While with shaping ribbon design, there will be atraumatic flexible tip with a better shapeability and shape memory. But support and control will be less with more chances of prolapse. Tip load is measured by advancing the wire into the standard surface until it deflects at the tip at a 2 mm with 2 mm deviation. It is primarily determined by core material and core thickness. So based on tip load, we can divide wires in three categories: soft wires, intermediate wires, and stiff wires. Soft wires has less than 3 gram tip load, while intermediate wires has 3 to 6 gram and stiff wire has more than 6 gram. Soft wires have tip soft and atraumatic, while stiff wires has used when there is a resistant nihilostenotic lesions. So workhorse daily routine workhorse wire has a low tip load, while wires which are used in CTO has higher tip load like Miracles, Confianza, Progress. Another key component of guide wire is body. It is the core of the wire which is surrounded by body, usually made up of coils and polymers. There are coils, cover, and sleeves. So first we will review coils. So coils is attached at the distal end of the guide wire where there is a core is tapering. Coils provide core maintain diameter and provide torque control and tactile feedback. Distal part of the coil has radio opacity, which guide during procedure. Another is cover. Depending on a polymer cover, wires are can be divided in fourth category. Either there is no cover, only spring coil. Either there is polymer jacket over entirety of spring coil. Either there is a polymer sleeve before the coated or uncoated and uncovered spring coil, and either there is a polymer without any spring coil. So what are the benefit of cover? The covering reduces the friction and improves the device interaction and guide wire tracking. There are two types of coating: hydrophilic coating and hydrophobic coating. Hydrophilic coating, as name suggests, attract the water and made surface slippery. So it will reduce friction, increase lubricity, and enhance tracking and crossing. But it also increases the chance of large dissection, entry into false lumen, perforation, and tendency to stick to catheter. While hydrophobic coating usually made of from silicone, it repels water to create a wax-like surface. It enhances tactile feedback and decrease the slipperiness and tackability. So when wire has no coating, it has best tactile feedback but lower the lubricity. And when we change from hydrophobic coating to hydrophilic coating and polymer cover, there will be reduction in tactile feedback but increase in lubricity. So wire can be divided based on polymer jacket and non-polymer jacket. Non-polymer wires are divided against in one core workhorse wire and heavier tip CTO wire. Workhorse wire include BMW wire, run-through wire, pro water, and samurai wire. While non-polymer heavier tip wire include Gaia wire, Judo wire, Miracle wire, Confianza, and Ornate wire. While polymer jacketed wire have low tip wire like Whisper, Pilot 50, Sion Black, Filter FC, and low tip with taper tip like Filter XT and Fighter wire. While polymer jacketed wire with heavy tip include Pilot 200 and Mongo wire. Now we have learned different components of guide wire. Now we review how to decide what guide wire to select in which kind of lesions. So there are four types of guide wire: workhorse wire, frontline finesse wire, extra support wire, and specialty wire. Workhorse wire are usually used in simple lesions, while frontline finesse wire are used in angulated and tortuous lesions. Extra support wire are used when there is excessive tortuosity and we want to deal with lesions which are very distal in artery, while specialty wires are used in CTO lesions. So these are different example of wires. Workhorse wires include BMW wires, promoter wires, Cougar, run-through wires, while frontline finish wire include Whisper MS, Whisper AS, Balance, Pilot 50, Filter FC, and Choice wires. While extra support wire include Grand Slam, Ironman, Mailman, and specialty wire include Crossit, Miracle Bros, Confianza, and High Pilot or High Progress wires. So what are the desirable characteristic of guide wires? So workhorse wires are safety and durability is the main characteristic we require in workhorse wires. While in frontline finish wires, we require 1 torqueability with excessive trackability without perforation, with minimal chances of perforation. Extra support wire, we require more support to deal with torches and difficult anatomies. While in specialty wires, we require a variety of tip stiffness and variety of either tapering with non-tapering and with moderate support. So these are the examples of workhorse wires. The workhorse wire has usually low tip load with 3 centimeter of radio opaque tip and non-tapering 0.014 each outer diameter. So we will review some key workhorse wires. The first one is balanced middleweight universal guide wire. It is the frontline guide wire which has unique balance of support and flexibility with improves device compatibility to deal with distal access and delivery in tortuous anatomy. Another is run-through NS wire. It has dual core of stainless steel and nitinol with straight tip and 30 mm radio opacity. Another is Sion blue and Sion wires. Sion blue wire has a 0.5 tip load and Sion has 0.7 gram tip load. We already discussed composite core technology which used in Asahi wires. We will discuss few more wires. So first group is polymer jacketed wires. It can be divided in tapered tip wires, non-tapered tip wires, and specialty wires. Tapered tip wires include filter XTA, filter XTR, where A stands for anterograde approach and R for retrograde approach. And another is fighter wire. So filter XT wire has long radio opaque segments at the tip, which is 16 centimeter long, while fighter has 3.5 centimeter long radio opacity. Another group is non-tapered tip polymer jacketed wires, which include Cyan Black, Filter FC, and Pilot 50, which has a relatively low tip load of 0.9 and 1.5 gram. And other group is non-tapered tip, but with high tip load wires, which include Gladius wires, Pilot 150, and Pilot 200 wires, which is a 3 centimeter long radio opacity segment. Now penetrating wires include a group of wires which has without polymer cover and with high tip load. So which include Confianza wire, Estato wire, which has a long radio opacity segment of 20 and 17 centimeter distal tip. While Hornet, Warrior and Infiltrate wire include a relatively low radio opacity segment. Now group of specialty wires include Gaia wire, Gaia Next wire, Judo wire, Miracle Bros and Suo wire. So Gaia wire has a tip load of 1.7, 3.5 and 4.5 in the first, second and third Gaia wire. While Gaia Next wire has also 4 categories 1, 2, 3, 4 which is 2, 4, 6 and 10 gram tip load. This Gaia category of wire has 15 centimeter radio opacity, while Judo and Suo has a relatively small 3 and 3.5 centimeter radio opacity segment. Now there are 3 kind of filter wire: filter XT, filter FC and filter. Filter XT wire has a tapered tip, while filter FC and filter wire has non-tapered tip. All 3 wire has a polymer cover with core to tip design. Now we will discuss 3 commonly used extra support wires: Ironman, Mailman and Gram Slam. This wire has a low tip load with 3 centimeter of radio peak length and non-tapered tip diameter of 0.014. So now we will review how to choose guide wire in different kinds of lesions. So non-complex simple lesions we will use a workhorse wire, while thrombotic lesions in soft thrombus we usually can be done with workhorse wires like BMW wires and run through NS wires, while organized thrombus will require soft polymer wires like Whisper MS and Pilot 50. In tortuous lesions, we sometimes we cannot cross with workhorse wires, then we will require workhorse wires with hydrophilic coating and soft non-tapered polymer jacketed wire or SUO wire. In lesions with critical calcified stenosis, soft polymer wires like Whisper, Sion Black and Pilot 50 are more ideal. While in LMC lesion and RC hostile lesion, routine workhorse wire are sufficient mostly, but sometimes we will require extra support guide wires. In bifurcation lesions, when we require to cross a side branch, then we will require hydrophilic wires like Whisper MS, Pilot 50 and Fielder FC. In CTO lesions, while integrate approach, we usually use polymer jacketed tapered wires or Gaia wires and Pilot 200 wires. While in CTO retrograde approach, we usually use Fielder FC, Sion and CO03 wire. In calcified CTOs, Confianza, Hornet 14 and Astrato 20 wires were used. While in difficult delivery, we require wiggle wire or support wires. Now we will discuss wire handling. So steering of the wire, we steer the wire by small rotatory movement to right and the left, and we usually avoid excessive rotation to avoid a risk of wire fracture. Shaping of the wire tip, a bend at the tip of guide wire allow it to be manipulated in with specific anatomies. Most commonly, we give the shape by shaping the wire between thumb and the index finger. We can also use the introducer and needle to shape the wire. Optimum guide wire position. So guide wire are placed in main branches as distally as possible to avoid perforation and to achieve extra support. So these are the different kinds of shaping of the wire tip. In figure A and B, there is simple J curve which has a distal bend with approximate to vessel diameter. It is used in simple straightforward procedures. While in figure C, D and E, we have two bend tip where distal bend is equal to tightest portion of the lesion and second gradual bend is equal to vessel diameter. It is used in more complex anatomies. While in F figure, there is a simple bend with less than 1 mm from the distal tip, which is used in CTO. So this figure help to visualize the two bends. Wire selection in CTO PCI. So first we will define the coronary anatomies with dual injection. Then we will decide whether to select anterograde approach or retrograde approach. Then according to approach, we will select the guide wire. In anterograde approach, either anterograde wire escalation strategy is most commonly used. And sometime while first guide wire enter in false lumen, then we can also select parallel wiring technique. In anterograde wire escalation technique, we first use low tip load polymer jacketed wire like Filter XT wire. If we are unsuccessful, then we escalate to non-polymer wire like Gaia second wire or polymer jacketed wire like Pilot 200 wire. And still we are unable to cross, then we can choose high tip load wire like Confianza Pro 12. So according to CTO stump, we can select different kinds of wire. In tapered stump CTO, we usually first choice is Filter or Filter XT wire. And if unable, then Miracle Bros and Confianza Pro wires can be used. In blunt stump CTO, we first use Miracle Bros and Confianza wires and can escalate to Progress 200 wires. In functional CTO, our first choice is Filter XT wire. While in bridging collaterals, first choice is Filter or Filter XT, and if unable to cross, then Confianza Pro and Progress wires. While in severe classifications, high tip load wires like Miracle Bros, Progress and Confianza wire used. So there are three techniques to cross CTOs: sliding technique, drilling and penetration. Sliding technique is used when there is presence of micro channels. CTO is relatively recent and when there is instant restenosis. For sliding technique, hydrophilic wires are preferred like Filter, Pilot, Whisper and Choice PT wire. In drilling technique is used when there is a CTO with discrete entry point, and when first attempted with soft intermediate wires has failed. So in this drilling, stiff and hydrophobic polymer jagged wires are used, like miracle bros, persuader wire, and crochet wires. In penetration technique is used when there is a blunt entry point with heavy calcification and resistance fibrotic lesions. So super stiff tapered wires are used, like Conquest Pro, crochet wire, and Miracle Pro wires. In dissection re-entry technique, we used Fielder XT wire, Mongo wire, and Pilot 200 wire. While in retrograde approach, while with septal wiring, we use Fielder FC, Sion Black, and Sion wires. While CTO retrograde with epicardial wiring, we usually use Sion and CO wires. These are the different complications which can happen with guide wire. It will be difficult to enumerate all complications and know about their management, but we will only enumerate these complications like plaque embolization, dissection, perforation, concertina effect, acute closure due to vasospasm, wire fracture, and wire tip entrapment. So take home messages of our today's discussion is: know your tools before you use them. No single wire suits every case. So proper wire selection is important. Right selection simplifies the procedure, and be gentle and patient when deal with guide wires. Thank you.